So, with all your permission, sir, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clearnet serves as a digital partner for this event. And the focus of today's session is tubeless anesthesia. And now I would like to invite Dr. L. Meenakshi Sundaram, sir, our distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions including governing medical member, president, and state secretary of the ISA Tamil Nadu state branch. And now I would like to hand over the session to you, sir. Over to you, sir.
Thank you, Clarnat. I'm very happy to welcome all the faculty and the delegate for this 35th webinar of Puthukkottai Bhudhan Second Edition. Today we are happy to have faculty from JSS Medical College and Higher Education, Mysuru, which is a popular institute. I have even visited the institute. Even though it is a private medical college, it will be flooded with the patients like a government medical college. So today we have the youngest faculty, Hrullekha. Actually, Puthukkottai Bhudhan has made it mandatory to include one postgraduate in every webinar to sensitize the younger generation who are going to be the would-be teachers. So Hrullekha is going to be a future Anil Kumar, and Anil Kumar was yesterday's Hrullekha. So now she had the opportunity to address a minimum 800 people who will be watching this webinar. And I thank the delegates for their consistent support for this webinar, even though it is conducted every week, because it is even rare to see these many people are attending. And Hrullekha is the youngest faculty today from JSS Medical College. She is doing her third year MD in JSS Medical College. And the first point is she is not married. So the Puthukkottai Bhudhan sometimes act as a matrimonial column. So I want to inform the delegates who are attending minimum 800 that this young lady doctor is waiting for her match, and they can easily see her now. So I have to offer some points. So she has done her MBBS from NRI Medical College, Andhra Pradesh. Why I am saying she is not from Karnataka, she is from Andhra Pradesh, native is Vijayawada, mother tongue is Telugu. I think this much is enough. I am having her phone number, so interested people contact me. It is going to be followed by Dr. Meghana. She is an assistant professor in JSS Medical College, Mysuru. She has done her PG from JN Medical College, Belgaum. She's at present she is assistant professor in JSS Medical College, but earlier she was a consultant in Narayana Healthcare. At that time, she was interested in thoracic and renal transplant anesthesia. But now, even her face is like a pediatric. So she is interested in pediatric anesthesia and patient safety. And she is having a good hobby. That is, she is interested in reading fiction. So it is real, even though she is reading fiction, it is true and real, I want to say. And it is going to be followed by that young gentleman, Dr. Anup, who is responsible for this webinar because he acted as a coordinator for me. It is a long time wait. We were waiting for 4 months to strike it together because it is a continuous blocking of the slots. So I'm happy now. Out of this 36, maximum 10 would have been from Karnataka only, because they have a long list of faculty. Even now, I have to clear 3 faculty. They are waiting in the pipeline, Karnataka. So I thank Dr. Anup for materializing this webinar. And he has done his MBBS from Devaraj Arts Medical College, Kolar. So whenever people like in Tamil Nadu, whenever they talk about Kolar, they will be talking about gold mine. But for me, the gold mine is Dr. Anup, because he has formulated this webinar, and he is a passionate teacher. That is what I want to emphasize. And his hobbies are entirely different. He is interested in traveling. So now they are saying traveling. In my school days and college days, parents used to bombard us if you are roaming around. Why you are roaming around all the city? Now they are making it as a hobby. They are making it as a hobby, saying that hobby is traveling. I don't know where they will travel. And see, while traveling, he will be singing also. I don't know whether he will be dancing or not. And he is interested in singing. And more the thing is fish keeping. Fish keeping, I don't know where he will keep all his fishes. Probably during his college days, he would have been interested in fishing. I don't know how many fishes he got at that particular point of time. I don't know. So to govern these sort of people, from Hrullekha, Meghana, and Anup, we need a powerful faculty as a moderator. So we have the powerful faculty, none other than Anil Kumar. Anil Kumar is a hero actually from Karnataka. See, we have invited him to Puthukkottai to conduct the ultrasound guided nerve block workshop. See, it is unbelievable. From 9 o'clock to 6 p.m., the same tone he was maintaining. I don't know what sort of a energy he has. Even I was attending only his session. Every time I'll go, and without exhibiting our ignorance, we will be standing there to see what is what. And he knows now, as a trained teacher, he knows we know nothing about it. And he has even colored the brachial plexus, everything. He has shown that. But the enthusiasm and the energy he maintains is unbelievable. That is a good quality of the teacher. See, the tone, it is echoing in the entire room. He was such a powerful teacher. See, definitely he is be powerful because in his MD, he secured a gold medal. So he is a Kolar man as far as anesthesia is concerned in MD exams, and he is a editor. See, being editor for one journal itself is very difficult, and he is a editor. He is a editor for Karnataka Anesthesia Journal and the Journal of Evolution of Medical and Dental Sciences. So naturally, he was invited internationally 15 times. Just because it is 15 times internationally, nationally one was added before that 15. So 115 invited lectures he has delivered in India, and he is a medical coordinator for Karnataka State Disaster Management Cell. So that is a honor for any anesthesiologist, and he is a member of Mission Smile. So it is an NGO organization to correct the facial deformities. So we used to say for cleft lip and cleft palate, it is a mission smile. That is the reason why he is always smiling, because his mission is to make others smile. So he is also smiling. He is a vice chairman for CSR committee, Rotary district. So Rotary International, we know. So in the district 3181, he is a vice chairman for CSR, corporate social responsibility, and he is an executive committee member for All India Difficult Airway Association. That is the reason why he is coming for tubeless anesthesia. Usually anesthesiologists are called man of endotracheal tube, but first time we are going to see the tubeless anesthesia, and he is a secretary for All India Difficult Airways Association also, and he is an executive committee member for Karnataka State ISA. He is the treasurer for Indian Society of Critical Care Medicine. Can you believe? He is a HOD in this JSS Medical College, and in addition, he is doing all these things, but he is not ready to stop with this. So as a human being, he has formulated a trust. So he is a founder trustee of Sai Foundation Charitable Trust. So that is really heartbreaking thing, because he is a managing director for Anupalana Griha. So he has shaped some home for the homeless orphans, girls aged more than 18 years. He wants to provide them education, vocational course training with free hostel facility. That we have to note. So boarding and lodging he is providing, and at present he is having 21 girls in his hostel, and majority are joining in hotel management, law, everything. I presume in due course, in future, medical graduates will also come from his home. So people will say, long live ISA. I say, long live Dr. Anil Kumar. So he is helping the society as well as the medical fraternity a lot. And with this introduction, I hand over the session to Dr. Anil Kumar. Please.
Thank you very much, Meenakshi Sundaram sir. Good evening, everyone. At the outset, I thank the ISA Puthukkottai City branch for having us on this prestigious academic platform of second edition of Puthukkottai Bhudhan to share our thoughts and experiences in the given topics. I had an opportunity, as Dr. Meenakshi sir has already spoke about, to meet and share our academic experiences with the president of ISA Puthukkottai, Dr. Munian, Secretary Dr. K. Kannan, and Treasurer Dr. Hema few months back. Myself and my team are extremely privileged and proud to be part of this Puthukkottai Bhudhan under academic chairmanship of Dr. Meenakshi Sundaram sir. We take this opportunity to congratulate sir for having been elected as ISA President National. Congratulations, sir. If you see the main discovery, a small correction with sirs. Presently, I'm not heading the department, sir. I'm a professor in the Department of Anesthesia. Coming to the topic, the main discovery and innovation in clinical practice was the introduction of endotracheal tube as a definitive airway in anesthesia management. Now, we are in an era where we are moving away from this ultimate innovation of endotracheal tube and doing airway surgeries without a definitive airway, that is without an endotracheal tube, called tubeless anesthesia technique, which is our theme of today's discussion. In this regard, in next 70 minutes or so, we discuss the physiology of the pre and para oxygenation, what is high flow nasal oxygenation, and the clinical application of this apneic oxygenation technique. With this, I welcome my third year resident, Dr. Hrullekha V, to present on physiology of pre and para oxygenation. Over to Dr. Hrullekha.
Thank you, sir. Good evening, everyone. I thank Indian Society of Anesthesiologists, Puthukkottai City Branch, and I thank Meenakshi Sundaram sir for giving me this opportunity to present. Now let us discuss about physiology of pre and para oxygenation. So what is pre-oxygenation? Pre-oxygenation is the delivery of 100% oxygen in a spontaneously ventilating patient for a classical period of 3 minutes, which results in denitrogenation of the lungs. This maximizes the period of safe apneic time following the induction of general anesthesia before arterial oxygen desaturation occurs. Before we go deep into the topic, now let us learn about some basics, that is about functional residual capacity. Functional residual capacity is the volume of the gas remaining in the lungs at the end of a normal tidal expiration. It reflects the balance between the outward chest wall expansion and lung collapse inward. The normal value is 30 ml per kg body weight, which accounts for in a 70 kg person. The FRC is around 2100 ml. So what is physiology behind desaturation and how does pre-oxygenation exactly help? So this is the graph which represents pre-oxygenation time in the seconds in the x-axis and stored oxygen ml in the y-axis. We can see that over a period of 3 minutes, the oxygen concentration does not much increase in the blood or in the tissue, but there is tremendous increase in the functional residual capacity as well as in the whole body. So pre-oxygenation increases the body oxygen stores, the main increase which occurs in FRC. The key to achieve maximal pre-oxygenation is by washout of alveolar nitrogen. So why pre-oxygenation for 3 minutes with normal tidal breaths? In this graph, we can see That time in the minutes is represented in the x-axis, and end tidal gas concentration, percentage of oxygen and nitrogen, is presented in the y-axis. Usually, when in the circle absorber, the air contains 80% of the nitrogen and 20% of oxygen. So as the time increases, exactly around 3 minutes, we can see that the 80% of the nitrogen downfalls, where it leads to ETN2, that is end tidal nitrogen to 5, whereas the ETO2, that is the end tidal oxygen, to 90%. Let us learn about time constant concept now. So the time constant of an exponential process relates to the time taken for the value of the exponential, in this case the amount of the nitrogen in FRC, to fall to 37% of its previous value. As a result, after 4 time constants, the process will be 98% completed. The time constant relates to the ratio of volume and the flow, that is functional residual capacity and alveolar ventilation. Now let us take an example clinically. For a 70 kg patient, the tidal volume being 7 ml per kg body weight, that is 490 ml, and respiratory rate, let us assume to be 12 per minute, anatomical dead space to be 140 ml when we take 2 ml per kg body weight, and FRC as discussed before 2100 ml, that is 30 ml per kg. Here the alveolar ventilation, that is the minute ventilation, is calculated by respiratory rate into tidal volume minus anatomical dead space, which accounts for 4200 ml. So the time constant is nothing but volume by flow, that is FRC by alveolar ventilation, that is 2100 by 4200, which is 0.5 minutes, nothing but 30 seconds. Therefore, in 30 seconds, nitrogen falls to 37% of its upper value. Henceforth, for complete nitrogen to get washed out, it takes 4 time constants, that is 0.5 into 4t, which gives us 2 minutes. The time constant and the relation of oxygen increase in the FRC. At 1 time constant, there is 63% of oxygen increase. At 2 time constants, there is 86% of oxygen increase. At 3 time constants, it is 95% increase. And at 4 time constants, it is 98% of oxygen increase in the FRC. The endpoints of maximal pre-oxygenation and denitrogenation have been defined as the end tidal oxygen concentration, that is ETO2, of approximately 90% and an end tidal nitrogen concentration, that is ETN2, of 5%. Now let us know about the relation between oxygen dissociation curve and desaturation. Farmery and Rowe developed and validated a computer model describing the rate of oxyhemoglobin desaturation during apnea. The model is particularly useful for analyzing oxyhemoglobin desaturation values below 90%. These values are dangerous to allow in the human subjects practically below 90% because there will be a steep decline of PaO2 because of the sigmoid shape of the oxyhemoglobin dissociation curve. So here in the x-axis, we can see PaO2 in mmHg, that is around 60 mmHg of the PaO2. Clinically, we can see the person has SpO2 of 90%. When we allow this saturation to fall down, this does not provide much more time for us to do any of the airway manipulations. So in a healthy 70 kg patient, when FiO2 is progressively decreased, the apnea time also decreases from 10 minutes to 3 minutes. Now let us learn about the effectiveness of pre-oxygenation. What is effectiveness? It is the sum of efficacy and efficiency. Efficacy is nothing but how well we pre-oxygenate the patient, that is ETO2 of greater than 90%. What is efficiency? It is nothing but how well we prevent the desaturation, that is prevention of SpO2 fall to less than 90%. So in a healthy person, the safe apnea period in the room air is about 1 minute. And if we provide higher FiO2s, the safe apnea period extends up to 8 minutes. Let us see the factors affecting pre-oxygenation. The factors which affect efficacy are presence of leak in the circuit, volume of the fresh gas flow, duration of breathing, the type of anesthetic breathing system used. Usually we use the circle absorber system where we provide 6 liters of oxygen per minute. When we try to use Mapleson circuit, we should provide twice the minute ventilation, that is 12 liters of oxygen per minute. The factors which affect the efficiency are alveolar oxygen tension, arterial oxygen content, systemic oxygen supply versus demand in the patient, functional residual capacity, and cardiac output. So clinically, there are 2 stages of pre-oxygenation. The first stage, which is washout of anesthesia circuit by oxygen flow, which is determined by the size of the circuit and oxygen flow rate. The second stage is accounted by washout of the functional residual capacity by the alveolar ventilation, that is FRC by VA. The techniques which we use for pre-oxygenation are tidal volume breathing for 3 minutes, or 4 inspiratory capacity breaths for 30 seconds, or 8 inspiratory capacity breaths for 60 seconds, or the breaths provided via high flow nasal cannula with 30 liters of oxygen. We also provide with the help of CPAP, BiPAP, and PEEP. Now let us see some clinical based scenarios that usually when we see the first one is in the pregnancy. In the pregnant population, there is decreased FRC due to gravid uterus compression on the diaphragm and increased VO2 due to growing fetus, which leads to rapid desaturation. But here is a paradox. The maximal pre-oxygenation can be achieved more rapidly in the pregnant women than in the non-pregnant women because of a higher alveolar ventilation and a lower FRC. The same accounts for the obese population. There is rapid desaturation in the obese people due to decreased FRC and increased alveolar oxygenation. So usually in the supine position enhances the decrease in the functional residual capacity because of the cephalad displacement of the diaphragm. So placing the severely obese patients in the 25-degree head up position during the pre-oxygenation has been shown to prolong the time of desaturation by approximately 50 seconds, that we can get up to 1 minute approximately. So here comes the concept of even para-oxygenation, that is the face mask pre-oxygenation should precede intubation attempts and should be continued with the placement of the nasal cannula or an oxygen catheter in the oropharynx. In the pediatric population, usually due to smaller functional residual capacity and higher VO2 than the adults, they are at a greater risk for developing hypoxemia when there is interruption in the oxygen delivery, such as during apnea or airway obstruction. Always remember, the younger the child, the faster the onset of desaturation. Most infants reach a SaO2 of 90% in 70 to 90 seconds after the onset of apnea in spite of pre-oxygenation. And this period can be even shorter in the presence of upper respiratory tract infections. So when we should usually incorporate the modified version of rapid sequence induction or intubation technique with emphasis on the complete muscular relaxation. That is the gentle manual ventilation using high oxygen concentration without cricoid pressure and sufficient anesthetic depth before intubation would seem more appropriate in the children. This graph is going to summarize the clinical scenarios which I have talked. So this is the time in the x-axis and the SaO2 saturation in the y-axis. We can see that in a normal 70 kg adult, the fall of the saturation may take up to 10 minutes. But in a moderately ill 70 kg adult and normal 10 kg adult, we get a time period of just 4 to 6 minutes. Whereas in the obese adult, that is around 127 kg adult, we have much more less time, that is 3.5 minutes. Always remember that everything doesn't come with only pros. There will be some risks and complications. So there are even potential risks for pre-oxygenation technique also. That is delayed diagnosis of esophageal intubation, absorption atelectasis, production of the reactive oxygen species, and cardiovascular responses. These are my references. Thank you.
Thank you, Dr. Hrullekha, for this comprehensive presentation on pre and the concept of para-oxygenation. Now I'll request Dr. Meghana to share slides. The HFNO was introduced, though it is not a new concept, it was introduced in the year 1968, primarily for the pediatric and neonatal purpose, mainly for the apnea of prematurity. It got FDA approval to utilize in adults on the corner of this present century. But the COVID-19 gave a momentum for the extensive utility of HFNO in the clinical practice. Now let us listen from Dr. Meghana about HFNO. Dr. Meghana? Dr. Meghana? Your slides, please. Meghana, share your slides. It into presentation mode. Yeah. Continue, please.
Good evening, everyone. At the outset, I would like to thank ISA Puthukkottai branch, Dr. Meenakshi Sundaram sir, and for giving me this opportunity, and Dr. Anil Kumar sir for guiding me through this presentation. The topic for today is high flow nasal oxygen. I have no disclosures and no conflicts of interest. Okay, now before we go to high flow oxygenation, let us first see what is low flow oxygen delivery. Now, every day we are using oxygen. It may be in the ICUs, it may be through our anesthesia workstations, it may be in the wards. Now, what is the oxygen that can be provided through these flow meters? In these flow meters, we can only provide 12 to 15 liters per minute of oxygen, and this oxygen can be delivered to the patient by means of a face mask or a nasal cannula. Now, if we have to provide flows more than this, now that is what is called as high flow oxygen delivery. Now, high flow nasal oxygen is delivery of oxygen via nasal cannulae. It can be done in patients who are awake, sedated, or under general anesthesia. Patients can be spontaneous or apneic, and the flow rate that is used is normally from 30 to 70 liters per minute. And the flow rates are generally kept higher for apneic patients. Now, to understand what is HFNO, let us look at the characteristics of HFNO. Now, HFNO consists of 4 H's, and we will see what they are. The first one is the gas that is provided in HFNO, whether it is 100% oxygen or an air oxygen mixture, it is humidified almost up to 100%. The FiO2 provided is high, and the important thing to remember is the FiO2 is constant. We can provide an FiO2 from 21% to 100%. It is heated from 31 degrees to 37 degrees, and it is high flow in the range of 60 to 70 liters per minute. An important thing here is these variables can be controlled independently. Now, why do we need this high flow nasal oxygen? The humidification, the high flow, the heating, and the high concentration. Now, it is because there are certain disadvantages when we give low flow air. The cold, dry air that we provide in low flow usually dries the nose, the oral cavity, and the throat, thereby causing inflammation. This also decreases the mucociliary clearance, and the cold, dry air causes bronchoconstriction, and also it causes increased airway resistance. And another important thing is the FiO2 that is delivered is not at all constant. All this leads to patient discomfort and poor tolerance and poor compliance by the patient. Now, that is why when we heat and humidify the gases, we can see the following effects. It hydrates the nose, the oral cavity, and the throat, thereby reducing the inflammation. The mucociliary clearance is increased. It minimizes the bronchoconstriction. It decreases the airway resistance, thereby decreasing work of breathing, which is very important. And it also prevents atelectasis, thereby prolonging the apnea time and improving oxygenation. All this definitely leads to better patient comfort and better tolerance and compliance by the patient. Now, let us see what happens when we provide gas at low flows and high flows. Now, when we provide low flows, that is our conventional methods, the patient's peak inspiratory flow rate is mostly not met. And due to that, there is some entrainment of room air with inspiration. This causes dilution of the air or oxygen that the patient is breathing, and the desired oxygen concentration is not met. Whereas when we give high flows, there is no dilution and the inspiratory demands of the patient are met. Now let us understand this with the help of this picture. Now, if we are providing, the first one is with low flows. If you are providing around 4 to 6 liters of oxygen to a patient through a nasal cannula, the FiO2 that is expected is 45%. But this patient is also entraining room air, that is at 21%. So the final FiO2 that is reached here is definitely not close to this 45%, but it is close to the room air oxygen concentration, that is 21%. This is therefore the low flow leads to dilution. Now, if we are delivering the same oxygen at 60 liters at an FiO2 of 45%, this room air entrainment is not seen, and the FiO2 that we get in the end is closer to 45%. Therefore, to deliver high amounts of FiO2 effectively to your patient, you not only have to match, but you have to exceed your patient's minute ventilation and inspiratory demands to minimize the oxygen dilution. Now let us look at the components of the high flow nasal oxygen system. Now the high flow nasal oxygen system consists of, first it consists of a flow meter. Now this is the oxygen flow meter. Now it may or may not have an air oxygen blender. This flow meter and the air oxygen blender needs to be connected to our oxygen and air pipeline source. Thereafter, there is a tubing that connects the air and the oxygen, and it connects it to the humidifier. This humidifier here sits on a heating plate. Then the gases from here are carried by this inspiratory circuit and goes into the patient interface, that is the nasal cannula. This inspiratory circuit here is heated. Now this needs to be heated to compensate for heat loss along the tubing and to prevent condensation. You can also see here, what you see here is a temperature sensor. One is present at the humidifier end and the other temperature sensor is present at the patient end. This wire that is shown here, only for representation purposes, it is shown outside. In reality, in the actual machine, it is inside this circuit. This is the actual HFNO apparatus. You can see here, this is a picture of the humidifier. This humidifier needs to be filled with sterile water, not normal saline, but distilled or sterile water, about 100 to 150 ml, depending on the instructions of the maker. You can see here, this is the patient interface, that is the nasal cannula, and this is the humidifier sitting on the heating plate, and these are the controls for the temperature. the cannula and the tubing size comes in 3 different sizes. Now let us talk about the interface that we are using. Now conventionally we are using interfaces like CPAP mask, oxygen mask or nasal cannula. Now these are usually cumbersome and patients tolerate them poorly. And a very important physiologic effect is that it increases the dead space, and it especially becomes important in ICU patients who are on the oxygen support for a long time because it interferes with talking, eating and clearing out of secretions. Whereas the HFNO interface is easier to implement, it decreases the dead space and it does not interfere with talking, eating or clearing out of secretions. It leads to better tolerance and better compliance by the patient. Now let us look at the physiology of high flow nasal oxygen. What are the mechanisms involving high flow nasal oxygen? Now the core requirement for high flow nasal oxygen to be successful is airway patency. This airway patency is required to enable the oxygen to pass from the upper airways to replenish the alveolar oxygen that is being consumed. The high flow rates that we see with the high flow nasal oxygen, because of the high flow rates, the inspired gases are preferentially drawn from the apparatus and there is no dilution by the ambient air. The next thing that happens is washout of the anatomical dead space by the high gas flow. This reduces the rebreathing of carbon dioxide. The third important thing HFNO does is that it generates a low level positive airway pressure. Now this positive airway pressure created helps to keep the airway open, and higher the flow rate is greater pressure is generated. And for a given flow rate, when the mouth is closed, the pressure that is generated is greater, and a mean pressure of around 1 centimeter of water per 10 liters per minute of gas flow has been estimated by various studies. You can see here what the oxygen does in the normal airway and what happens to the oxygen that is delivered through a HFNO apparatus. Here you can see the yellow color is all the carbon dioxide and here this is oxygen. Whereas in a HFNO, the entire upper airway is flushed with oxygen. Thereby, it decreases the nasal resistance to the movement of oxygen. There is decreased dead space. Now, these gases create a kind of turbulent primary supraglottic vortex. Now, what does the supraglottic vortex do? The supraglottic vortex that is created by the high flow nasal oxygen, it continuously washes out the upper airways and it provides a reservoir of oxygen in the upper airway that is available for gas exchange. And it also avoids rebreathing of carbon dioxide and therefore helps in decrease of the anatomical dead space. The supraglottic vortex bypasses the upper airway, decreases the resistance of the respiratory system to the airflow by almost 50%. Now let us look at, now we saw what happens in the upper airway and what happens when the supraglottic vortex is created. Now what happens below that? Now below that, there is, as the oxygen okay. Now, after the oxygen passes from the supraglottic area down below, in the apneic patient, extraction of oxygen from the alveolus into the blood, it causes the alveolar pressure to become subatmospheric. This then generates a pressure gradient which enables the movement of additional administered oxygen into the alveolus. Now, this entire movement of oxygen into the alveolus is called aventilatory mass flow. Now, this aventilatory mass flow is also facilitated by denitrogenation of the patient's lungs, as Dr. Hrullekha was mentioning before. That is breathing oxygen for a suitable duration before the onset of apnea. Now, the persistence of nitrogen in the lung, along with the accumulating carbon dioxide, diminishes the pressure gradient available for oxygen transfer to the alveolus, hastens the onset of hypoxemia. Therefore, it is important to denitrogenate the patient. And renitrogenation is prevented by the delivery of 100% oxygen during the apneic period. Now, the subatmospheric alveolar pressure also promotes the carbon dioxide transfer from the blood to the alveolus. And this pressure gradient is not immediately obliterated, as the degree of oxygen extraction from the alveolus exceeds the degree of carbon dioxide returned to the alveolus. So what happens with time? The alveolar accumulation of carbon dioxide, it diminishes the pressure gradient for the oxygen transfer to the alveolus. And this is one of the main reasons for limiting the success of aventilatory mass flow for a longer duration of time. So as you can see here, this is a picture showing spontaneous respiration where there is normal gaseous exchange. And nowadays it has been proposed that the term hypoventilatory mass flow be used rather than aventilatory mass flow that has been described, because there is some carbon dioxide exchange happening and not zero carbon dioxide exchange as it was thought earlier. So with higher flow rates, the carbon dioxide exchange increases, and therefore the term hypoventilatory mass flow has been proposed. The next mechanism that is responsible for this movement of high flow nasal oxygen is the cardiogenic oscillations. Now, during systole and diastole, there is change in the heart volume. This changes is transmitted to the vessels surrounding the tracheobronchial tree, and this then generates compressive or percussive force on the adjacent airway, which is thought to promote gas movement. Direct compression and expansion of the lung parenchyma adjacent to the heart and pulsatile flow in the pulmonary vasculature also contribute to movement of gas. This mixing is predominantly thought to occur in the conducting airways. Now let us see what happens to carbon dioxide clearance. Now during normal spontaneous ventilation, partial pressure of carbon dioxide is highest in the mixed venous blood, then in the alveolus, and then in the arterial blood. Now during the initial period of apneic oxygenation, venous, alveolar, and the arterial partial pressure of carbon dioxide transiently reach equilibrium. After some time, this equation that was described earlier above is reversed, and the arterial carbon dioxide that is PSCO2 exceeds the venous partial pressure of carbon dioxide. Now, why does this reversal happen? This reversal is attributed to the retention of carbon dioxide within the pulmonary circulation due to impaired gas exchange. Now, apneic oxidation with HFNO, it augments the elimination of carbon dioxide. Almost 2/3 of the carbon dioxide produced is eliminated from the body. It attenuates the rise of carbon dioxide in blood with mean elevations of about 1 to 2 mm Hg as found in various studies. Now, as time progresses in apneic oxygenation, the gradient between the PaCO2 and the EtCO2 increases. Now, this is because of atelectasis and ventilation perfusion mismatch. As you can see from this graph, even at about 30 minutes of apnea time, the partial pressure of carbon dioxide has not reached even 75 mm of mercury. In our institute, we have done cases with a safe apnea time of 63 minutes with no deleterious effects to the patient. Now, what are the limiting factors? Why can't we go on continuing this apneic oxygenation for a long time? One of the most important factors is atelectasis. Now, supine positioning of the patient, GA, general anesthesia are already thought to contribute to atelectasis. Along with that, decreased pressure in the alveolus as time progresses also contributes to atelectasis. And next, with time, the alveolar accumulation of carbon dioxide diminishes the pressure gradient for oxygen transfer to the alveolus, and this limits the duration of success of aventilatory mass flow. Also with time, as the EtCO2 rises, hypercarbia and acidosis also come into picture. Now this diagram will summarize the physiology of high flow nasal oxygen. As you can see here, the positive airway pressure is one of the first factors. This positive airway pressure that is generated helps in keeping the airways open. It acts as a stent to open the airway. The next one is dead space flushing, which we discussed about. Then cardiogenic oscillations, which have a percussive effect on the airways. And then this is the mass flow of oxygen, called aventilatory or hypoventilatory mass flow. And this is the carbon dioxide clearance. Okay, next, now we saw how HFNO works. What are the mechanisms by which it works? Let us see what this does. That is the physiological effects of HFNO. The first physiological effect of HFNO is increased apnea time and CO2 clearance. The next is gas conditioning. This humidification of gases, as we already spoke about, helps to prevent drying of secretions, which can lead to mucus plugging. And the gas conditioning also helps to prevent atelectasis and hypoxia. Reduction of dead space. And the next would be dynamic positive airway pressure. Let us talk about reduction of dead space. Now, what happens is that HFNC is an open system and it flushes out all the carbon dioxide in the anatomical dead space. We saw earlier how the supraglottic vortex helps in this. This decreased dead space helps in decreased work of breathing, and HFNC is the only non-invasive system that does not increase the dead space. Now, dynamic airway pressure. Now, the positive airway pressure that is created causes a lot of things that helps in HFNO. It causes a reduction of the nasopharyngeal airway resistance. In a spontaneously breathing patient, the nasopharyngeal resistance contributes to almost 50% of the work of breathing done. So HFNC definitely reduces the work of breathing by reducing the nasopharyngeal resistance. Next, it also provides PEEP. This PEEP helps to prevent atelectasis, it decreases dead space and improves the oxygenation. Dynamic airway pressure also helps to reduce the upper airway collapsibility and distal airway atelectasis. The PEEP that is provided usually is about 1 centimeter water for every 10 liter of flow. And the positive pharyngeal pressure is affected by flow. That is, higher flows, higher pressure is generated. Mouth closed, higher pressure is generated. And BMI. Patients who are obese will require a higher pressure to keep their airways open. Now let us look at the factors that affect the work of breathing. During spontaneous breathing, that is without volume or pressure support, HFNC can decrease the work of breathing. These are all the factors that are involved to decrease the work of breathing. That is the washout of nasopharyngeal dead space, inspiratory resistance reduction, improved pulmonary compliance, reduced metabolic work that is associated with gas conditioning, and improved pulmonary recruitment, that is prevention of atelectasis. So all these factors help in reducing the work of breathing. Okay, to sum up, this is the physiological effects of high flow nasal oxygen. So you can see that high flow during inspiration, we have high FiO2. It overshoots the peak inspiratory flow of the patient. There is alveolar recruitment and redistribution of the tidal volume. During expiration, it can provide a PEEP effect. Alveolar recruitment is done and there is dead space washout. All this eventually leads to improvement in the partial pressure of oxygen, and it also helps in washout of the carbon dioxide. Humidification and heating helps in better comfort and compliance of the patient. All these factors work together to ultimately decrease the work of breathing in the patient. Now, HFNO or Thrive in anesthesia practice is a newer entity. However, it has been used in ICU for quite some time. So in a patient who is in respiratory failure in the ICUs, the following clinical effects can be seen after HFNO is started. Now, it reduces dyspnea by 5 minutes, within 5 minutes of 10 minutes. It decreases the respiratory rate. It improves oxygenation within 15 minutes. Supraclavicular retractions and thoracoabdominal asynchrony also decrease within half an hour of starting the HFNO therapy. Now, this is about physiology and clinical effects of the HFNO. Now, let us see where it is contraindicated or what are the conditions in which we need to use HFNO with care. The first one would be use of alcohol-based skin preparation solutions. This is mainly in laser surgeries. Since we are using a high flow nasal oxygen, there is a propensity to cause airway fires. Any known or suspected skull-base fractures and CSF leaks, or any other communication from the nasal to the intracranial space. Significant pneumothorax which has not been treated because the CPAP effect may expand the pneumothorax. And of course, complete nasal obstruction, active epistaxis, and recent PES surgeries, as the nasal passage is the conduit for high flow nasal oxygen. The limitations of high flow nasal oxygen. Now, as we understood earlier, one of the core requirements of high flow nasal oxygen is a patent airway. Also, during the high flow nasal oxygen, patient cannot receive any volatile agents. So, giving the patient TIVA is a must. The increase in arterial carbon dioxide usually is one of the factors which limits the duration. The rate of increase of carbon dioxide cannot be measured reliably by EtCO2. Nowadays, there are nasal cannula with adapters to measure the EtCO2. Though it's not reliable, it can help us in gauging the trends of the EtCO2. Next, coming to the complications of HFNO. As we already discussed, it is to be used in caution in laser surgeries as there is a chance of airway fire. This can be decreased, the chances of this can be decreased by using a lower FiO2. The next complication would be hypercarbia related. As we all know, hypercarbia can cause significant tachycardia, hypertension, and if prolonged, can cause fatal arrhythmias. There can also be worsening of pulmonary hypertension. Gastric insufflation, in studies done, it was not as significant, and the studies have said that gastric insufflation with HFNO is actually lesser than the gastric insufflation seen with face mask ventilation. Pneumocephalus can occur if there is any communication to the cranium. Airway soiling, that is, if there is any vomitus, any blood, that can lead to airway soiling if HFNO is given. Aerosolization, that is, any droplets that are present, any infective viruses that are present, there is a risk of aerosolization. Earlier, this risk was thought to be significant. However, with the use of HFNO and Thrive during the COVID, this is a minimum risk. Also, the other thing that HFNO can do is misplace confidence. What I mean by this is that a difficult airway, which requires, say, an awake fiber optic intubation, can be missed because you have the confidence of saying, oh, I have HFNO, let me try something. So that is misplaced confidence. Now let us come to Thrive. Now Thrive is transnasal humidified rapid insufflation ventilatory exchange. Now Thrive is just a means of providing the high flow nasal oxygen, and it is a mechanism for oxygenating and ventilating patients who are under general anesthesia, who have diminished or absent respiratory effort. Now the term Thrive was not in use before 2015. In 2015, a landmark article was published by Dr. A. Patel in the Anesthesia Journal, and since then the term Thrive has been used, though it is an extension of high flow nasal oxygen. As we all know, HFNO or Thrive is being increasingly used in anesthesia practice. There are various studies which are being done to compare the effectiveness of HFNO, standard face mask for pre-oxygenation, which have shown that HFNO definitely has a role HFNO is definitely a role in improving the apnea time. So there is definitely scope for research in this area. This is another editorial written by Dr. A. Patel, who coined the term Thrive, that is face mask or high flow nasal oxygenation, time to switch. Again, it is said that it increases the apnea time and can be beneficial in a variety of clinical scenarios. The clinical applications of HFNO and Thrive are many. It can be used in difficult airway situations, shared airway, procedural sedations for NORA, and in patients where there is physiologically reduced oxygen reserve. My colleague, Dr. Anup, will be talking extensively about all these clinical applications. Thank you.
Thank you, Meghna, for that crisp presentation on the anatomy, physiology, the working principles, the limitations, contraindications, and the complications of high flow nasal oxygen. One caution of word should be exercised. Anup, you can start sharing meanwhile. Meghna, you unshare your screen. One caution of word we need to exercise while using HFNO is, though it looks an attractive airway management technique, the optimal, the preoperative, the standard preoperative assessment, the preparation, and the management of airway with proper positioning of the patient, maintaining the airway patency, good mask seal, and the para-oxygenation techniques are the key to success. But you need to be very, very careful whenever you want to translate these applications into clinical practice. Let us listen from Dr. Anup how these learned concepts of pre-oxygenation, para-oxygenation, high flow nasal oxygen, apneic oxygen technique into clinical practice. Over to Dr. Anup.
Thank you, sir. At the outset, I would like to thank the ISA Puthukkottai branch and Meenakshi sir for giving me this opportunity for the second time. 3 years back, I was here, and again, I'm here with my team of experts. Thank you so much, sir. So I'll be talking about clinical applications of apneic oxygenation. So till now, we've learned what is pre-oxygenation, para-oxygenation, what is HFNO, what is Thrive. But knowing all this comes to use in OTs and ICUs, and let us see how this happens. I bring greetings from my parent institute, that is JSS Medical College and Hospital, Mysuru. I have no disclosures, no conflicts of interest, and I have taken consent from all the patients that clinical information that I'll be sharing today. So I'm going to start where Dr. Meghna stopped. So this is where we are now. So who thrives? What do you mean by who thrives? Where we can use Thrive or HFNO? So the first is difficult airway. Definitely in difficult airway, it is, as Dr. Meghna was telling, it is going to increase the apnea time. So we have a lot of time to manage the airway. Then a shared airway, especially during airway surgeries, HFNO and Thrive can be of great help, which I'm going to talk to you all about in detail in my future slides. And next is procedural sedation or in non-operating room anesthesia is of very importance, especially in bronchoscopy, endoscopy, or even in ECT, we are using this very, very efficiently. And in patients with reduced oxygen reserve, it is a boon, especially pregnancy, sepsis, obesity, such conditions, this HFNO is of great significance and is of great help to the patients. So in 2010, Richard Levitan came up with the concept of no desat. What do you mean by no desat? It is nasal oxygen during an effort to secure a tube. Okay, what he tells, it is a very simple concept. Whenever you're trying to intubate, just place a nasal prongs in the nose and give the patient nasal oxygen around 10 to 12 liters, maximum 15. So this was widely picked up by people, and finally an article was published in the Annals of Emergency Medicine, which shows the importance of no desat technique. So where are we using this concept in ROT? This is all ROT, which I'm showing the pictures of are. So Thrive we use for pre-oxygenation. As told by Dr. Meghana, pre-oxygenation with HFNO increases the apnea duration. So you can see here, as soon as the patient comes, we connect them to the nasal prongs, connect them to the Thrive machine, and as you connect the monitors, the patient is getting pre-oxygenated simultaneously. And one more thing I want you all to notice is the 25-degree head up lift that we have given. So the FRC is going to increase with this head up position, and the oxygen reserve is going to increase further. And once we started during the pre-oxygenation, we continue till we secure a tube. That is called as no desat. So no desat also we are following here in our institute. It has also helped us in cases of unanticipated difficult airway. This is a very tricky situation. We had this small boy, 11 years, for appendicectomy. And once we induced, he went in for airway obstruction. You can see the second picture, there is paradoxical breathing and indrawing of the chest. So we had the Thrive machine just there in the ENT OT. We connected it, kept his airway open, paralyzed him, and then intubated him. You can see the saturation is 100 even during all this period of time. So that is how Thrive can help in unanticipated difficult airway. So ECT is again a very common picture. You can see our moderator, Dr. Anil Kumar, using Thrive for ECT. So in ECT, we're gonna paralyze the patient for a very short time. So the patient will be apneic. The regular practice is to hold mask and ventilate with the back. But with the advent of Thrive, you can just keep the jaw open and give them oxygen till the patient breathes spontaneously. Now I want you all to look at this video. So your ENT friend calls you and tells you that this patient is posted for tomorrow. So same thing happened to us. They gave this diagnostic pitch video and told that this patient will be posted tomorrow. Okay, we went ahead, we induced, and we tried to see what has exactly happened with a video laryngoscope. So you can see a huge mass sitting in the glottic opening. We somehow passed a tube and the tube was sitting like this. The surgeon was not happy at all. He said, "How can we operate?" Similar picture is with this lesion, where the lesion is in the posterior part of the glottis, especially in the arytenoid region. If we place a tube, the lesion gets obscured. There is no way the surgeon is going to operate. What does the surgeon wants here? Surgeon wants an unobstructed view of the airway, no or minimal movement of the vocal cords. So he has pushed the challenge to us. It is your headache, do whatever you want. What is your plan for airway management? So looking at all these challenges, finally, what we can plan is some form of tubeless anesthesia. What do you mean by tubeless anesthesia? Why tubeless anesthesia is important is my area of concern in my future slides. So tubeless anesthesia is one of the important applications of apneic oxygenation. To define, tubeless anesthesia is a specialized skill. One second. Sorry for the technical glitch. A specialized skill of providing a tubeless field without a definitive airway, yet providing an appropriate strategy for oxygenation and anesthesia. So what we are trying to tell here is we are not having a definitive airway, but still we are doing something to maintain oxygenation and ventilation. Though there is no proper definition, there is no universally accepted definition over here. We are using this working definition for the use of tubeless anesthesia. So I want you all to look at this 4-minute video to see how a tubeless anesthesia works. So this is a laser surgery on the laryngeal inlet that is happening. And we can see Dr. Meghana, Dr. Anil sir in the picture. So what we had done was we had induced the patient and we are maintaining the patient with TIVA because we can't give inhalation as Dr. Meghana was telling. We had maintained the patient with TIVA with muscle relaxant and the surgeon with Thrive in the nose. The surgeon is comfortably operating. That is the blue laser that our hospital ENT surgeons are using. And that is a new invention into the armamentarium of lasers, which has very, very less chance of having airway fire. So suddenly there was some amount of desaturation as the surgeon continued to operate. But as the desaturation further continued, we went ahead to secure the tube. So instead of asking the surgeon to remove the suspended laryngoscope, we gave a microlaryngeal tube to the surgeon himself. Since the glottis is under vision, we asked him to pass the tube. So now the surgeon is trying to pass the tube without hampering the suspended laryngoscope. So we can see the tube going in, and we started to ventilate the patient to improve the oxygenation. So this was our plan B. I'm going to talk about all this in the future slides. Just have a look at this video and we'll discuss about this in future. So the surgeon continues to operate. That the blue light is the laser with the excision. So after the excision of the anterior part, there was still some amount of lesion left in the posterior part that was being covered by the tube. So we again go ahead to a tubeless technique where we remove the tube and allow the surgeon to operate. So now the tube has been removed and the surgeon removes the lesion that is left in the posterior aspect of the glottis. So once that is done, he achieves hemostasis and the procedure is done. So the surgeon is removing the working laryngoscope over there. And now the patient is still paralyzed. So what we do generally is place a supraglottic airway device till the patient returns to spontaneous ventilation. So once the supraglottic device has been placed, iGel in this case, we stop the nasal oxygenation or the HFNO because that cannot reach the glottis. Now we continue to ventilate. I want you all to observe the bottom EtCO2, which reads around 66 now, because the ventilation was not a regular ventilation, it was an apneic ventilation. The EtCO2 had gone to 66. Now we ventilated the patient adequately till the EtCO2 came back to normal of around 40. So once the EtCO2 is back to normal and the patient is breathing spontaneously, we have kept the nasal cannula intact because even we can use it in the post-extubation period to supplement oxygen. So once the patient is awake, we are removing the supraglottic airway and continuing nasal oxygen in the Thrive machine. See, the patient is awake, showing a tongue. The patient is comfortable. So this is how we do our cases in ROT. Why tubeless anesthesia in airway surgery? Tubeless anesthesia is of great importance, especially in airway surgeries. Why tubeless anesthesia for airway surgeries? Just now, as you said, as we saw, if there is a tube in the glottic region and there is a lesion over there, it avoids bulky ET tube. The surgeon cannot operate if the ET tube is there. Hence, this will give a tubeless field. If there is no tube, surgeon is more comfortable. There is better access for lasers, microdebriders, and even dilatation if there is tracheal stenosis. And we can also ventilate distal to the stenosis. As with any other techniques, this also has its own risks associated. What are these risks? One is collapse. Now the airway is, you have not secured a tube, the airway is open and you induce, there is always a probability of the airway collapsing. There is no tube, no inflation of the cuff, the airway is open, so there is a risk of aspiration. The airway is insecure. Because again, it is an open system, there is chances of gastric insufflation and gastric distension. And since it again is an open system, as Dr. Meghana was talking, EtCO2 monitoring becomes extremely difficult. So what I want you all to understand is with just one ET tube in place, all these risks are averted. But in our tubeless anesthesia technique, we are not placing a tube. So all these things can happen and we should be extremely careful. Another important point is it is a shared airway. So the ENT surgeon and the anesthesiologist are fighting for the airway. So we should be double cautious in taking care of the patient. And we should always maintain a balance between depth of anesthesia and spontaneous respiration, because laryngoscopic response is a very, very strong pressure response. So if we don't provide adequate depth, the stress response of the heart rate, blood pressure is going to skyrocket. Hence, adequate depth is absolutely necessary. But on the other end, if you produce adequate depth, then the respiration can get hampered, the recovery can get hampered. So we should extremely be careful in balancing these two. As with any other surgeries, we have goals for tubeless anesthesia as well. What are our goals? First thing is to provide an unobstructed view of larynx to the surgeon. And there should not be any movement of vocal cords for him to operate and operate quickly. Secure airway. Now we are not putting in a tube, then how do we secure an airway? That is where patient selection becomes very, very important. Tubeless anesthesia cannot be done for everyone. It has to be on selected patients based on your understanding of the physiology. Especially in obesity, patients with restrictive or obstructive lung diseases, you cannot just jump into tubeless anesthesia. Then we should provide adequate oxygenation and ventilation, which can be efficiently done with the machine Thrive. We have to again ensure that the depth of anesthesia is adequate and the patient also recovers smoothly in the post-operative period. Because lasers are being used in the airway surgeries, airway fire is always a complication that we should think of, and we should always keep things ready to minimize those airway fires. So our condition is like this: walking on a tight rope. The elephant is the anesthesiologist and the patient is the giraffe. See, the giraffe has nothing to do. It truly believes the elephant. So it is the responsibility of us, the anesthesiologist, to walk this rope carefully so that the patient or the giraffe doesn't fall down. Then how do we manage this airway safely? This depends on a coordinated efforts of the patient, surgeon, and the anesthesiologist. Whatever is the plan A, plan B should be discussed between the surgeon and the anesthesiologist. So both should be thinking on the same lines and both should know what is the next step if something happens. Similarly, all these things need to be explained to the patient in a colloquial way and to make them understand. And if their efforts are needed, if we are doing an awake case, what are the responses from the patients that is expected should be explained to them. So always remember 3 P's. Plan your primary anesthetic management and plan your backup. So what is your primary plan and what is your backup plan? This should be decided by the anesthesiologist and surgeon before entering into the OT. Prepare. What you need to prepare? You have to prepare yourself, you have to prepare the patient, you have to prepare your equipments, and you have to prepare your assistants and your help to handle this case. Only then you are ready to perform a tubeless anesthesia surgery. So what are the indications of tubeless anesthesia surgery? Most commonly, we use it for DL-scopy and biopsy. Laryngeal surgeries, various forms of laryngeal lesions we get papillomas, tumors, vocal nodules, laryngeal web, hemangiomas. All these things can be safely handled, and we have safely handled in our institution using tubeless anesthesia with Thrive. Tracheobronchial surgeries like tracheal stenosis or diagnostic tracheoscopy, foreign body removal, tumors, are all these things which are commonly handled using a tubeless technique. This is where, in this procedural sedation is where it is of great importance, where the margin of error is so less. So Thrive can be used in DICE. We regularly use in DICE. What is DICE? DICE is drug-induced sleep study. Especially in patients with obstructive sleep apnea, we put them into sleep and see where the airway is collapsing. So in this time, we use continuous nasal oxygen to Thrive machine, and the patient maintains a good saturation. And ECT, as I explained you before, upper GI endoscopy, bronchoscopy, and difficult airways, especially apneic fiber optic bronchoscopy, and especially in uncooperative pediatrics where some amount of sedation is definitely needed. We have also used it for tracheostomies and laser surgeries. So these are some of the lesions that we have operated in our institute. So where you can see so many tracheal stenosis, mass lesions, and so many of the times we have not had any problem with Thrive. So what type of anesthesia we provide when we are doing a tubeless anesthesia? PAE and patient selection are very, very crucial, because just now I told you how selection of patient becomes very important. I don't want to elaborate it on it again. Pre-oxygenation, Dr. Hrullekha has extensively told why it is important. And Dr. Meghana also said one of the disadvantage of high flow nasal oxygenation is you can't give inhalational agents. So we have to depend on total intravenous anesthesia with neuromuscular block. So we generally use in our institute, we practice using propofol, dexmedetomidine, and infusion of propofol continues with the Tiva machine with fentanyl. In the past 2 months, we have received ramifentanil, which is being used now. And since there is lot of changes in the saturation and EtCO2, considering it a tubeless anesthesia, this monitoring becomes extremely important. As I told you before, always have a backup plan ready. That is, you should be able to switch back to rigid bronchoscopy or put in a tube and ventilate in a conventional manner, how we did in our case, the video which you saw. Or if there's a very tight stenosis, always be ready for an emergency tracheostomy. One advantage here is because most of these surgeries are done by ENT surgeons, they're always ready for tracheostomies. So if there is something wrong, don't hesitate to switch back to your conventional methods. So we now induced, how do we maintain oxygenation and ventilation during tubeless anesthesia? What are the interfaces? The first interface is bag and mask ventilation. So many procedures we have done with bag and mask. Do we call it as tubeless anesthesia? Though it can be called as tubeless anesthesia, the term tubeless anesthesia is still restricted to only those airway surgeries we do under tubeless anesthesia. Okay, so be very clear, tubeless anesthesia refers to those surgeries done on the airway without securing a tube. So other mechanisms are through nasal prongs, nasopharyngeal airways, your supraglottic airway devices, and a ventilating bronchoscope, which I think all of you must have used a ventilating bronchoscope, especially in removing a foreign body in a child. So all of you would have definitely practiced some form of tubeless anesthesia by now. But in this presentation, I have put it very concisely how you should go about it, especially for airway surgeries. And next is high frequency jet ventilation, which I'm going to explain in the later slides. And most commonly used interface is the high flow nasal oxygen or the Thrive machine. So here, one important point that we need to remember whenever we are using Thrive, we should stress on the point that the airway needs to be kept open, either with a jaw thrust or place a nasopharyngeal airway and place the nasal cannula in that. At all point of time, the airway should be kept open for this to function. This point you should always remember. Now, what are the techniques? What is this intermittent apnea technique? This is like a musical chair. You induce the patient with your induction agent, muscle relaxant, everything, ventilate the patient, or you put in a tube. Then, once the patient is comfortable, saturation is 100%, EtCO2 is normal, then you come out. Either take out the tube or take out the mask, surgeon will start operating. So, once the saturation falls to below 95, going to 90, ask the surgeon to move away, put your tube and start ventilating again. So this is how intermittent apnea technique works. But the problem associated with this technique is the time the surgeon gets is very, very minimal. And it is very risky. If there is some bleeding, it can just trickle down into the trachea, into the lungs. So this is, though we use this technique for short procedures, we always prefer using Thrive and as safer options for a longer duration procedures. So this is one intermittent apnea technique which we used 3 days back. So this was a patient with tracheostomy and he was decannulated, but within 2 days he came back with a stridor. So they had done an emergency tracheostomy in the emergency to secure his airway. Now they wanted to see why he developed a stridor, and once they did a scopy, they found granulation tissue in the stoma. So they wanted to do a dilatation, and I had induced the patient with propofol, continued nasal oxygen, and given succinylcholine, and the procedure was to dilate the trachea. Once I induced the anesthesia, patient was comfortable. I came out and gave the field to the surgeon, and surgeon started to dilate the lesion. Once the dilation was complete, the trachea was wide open. So this is how we do a crossfield technique. So once this was done, again, the tracheostomy tube was put in place and the patient had a safe airway. Now I'll show you a video on where Thrive has been used for a posterior cord nodule, which was removed under tubeless anesthesia. So the patient is already induced with Thrive in place. Now surgeon puts in the laryngoscope. In this case, the surgeon himself will keep the airway open. You need not worry about it. Because of the laryngoscope, the surgeon himself keeps the airway open. So you can see the nodule in the posterior part of the vocal cords. Saturation is 100%. Everything is stable. Anesthesia machine is not in use. Only the Thrive machine at 60 liters is being utilized. So the surgeon removes the nodule over there and also finds a nodule hidden there. If we had put in a tube, we would have missed that nodule. So that hidden nodule also was removed. So once that was done, hemostasis was achieved through small cautery. Once hemostasis was satisfactory, the scope was pulled out. See again, we can see Dr. Anil giving jaw thrust to keep the airway open now. And we mask ventilated this patient and the patient was awake. So the total duration of surgery was 29 minutes and the procedure was 45 minutes. Without any fall in saturation, we could manage this case. So we saw how Thrive can help in tubeless anesthesia surgeries. Now we'll see how high frequency jet ventilation can be of help. So what is high frequency jet ventilation? It is characterized by delivery of small tidal volumes at high pressures at very high frequency followed by passive expiration. I want you to remember these four underlines that I have done. For high frequency jet ventilation, we provide small tidal volumes at high pressures at very high frequencies, that is 60 to 100 per minute, and the expiration is always passive. So high frequency jet ventilation can be provided by two mechanisms. One is, this is a manual mechanism where you connect the manujet into oxygen source, you regulate the pressure, and how do you activate is through the handle that is there. When you press that, that jet is delivered to the patient. But this is a high frequency jet ventilation ventilator, which we don't use or we have not seen even. But this offers a very controlled environment for high frequency jet ventilation, where you can set the driving pressure, you can set the frequency, you can set the inspiratory time and the expiratory time. So this is very, very advanced technique, advanced equipment. And usually we find this in the US literature. As of now, we have not seen anything of this sort in India. So how do we give this jet ventilation? There are three different techniques: supraglottic jet ventilation, transtracheal jet ventilation, and subglottic jet ventilation. So what is supraglottic jet ventilation? Just like our ventilating bronchoscope, we have jet ventilating laryngoscopes. That means these are specialized laryngoscopes which has a port where we can connect our jet ventilator. So once the surgeon places the laryngoscope, you can connect the jet to the jet nozzle and start jetting the patient, and the surgeon continues to operate without any problem. This is a newer advancement of supraglottic jet ventilator. It is called as the Way nasal jet tube. That means it is just like a nasopharyngeal cannula, nasopharyngeal airway. If you look at it, it is just like a nasopharyngeal airway with two additional tubes embedded in it. So you can pass this through the nose and it will sit above the glottis, and through one of the tubes you can connect to the jet. The other tube will give you ETCO2. This is a very advanced system which has been recently introduced. Now, what is the advantage of supraglottic high frequency jet ventilation? The most important is it gives us the tubeless field that we always want it. But what are the disadvantages? It increases the pressure, airway pressures very, very rapidly. The surgeon needs to maintain the airway. That means if the surgeon moves around the scope, then the axis of alignment of the jet and the airway is distorted. Always the axis and the jet, airway axis and the jet should be in the same line. If there is malalignment, then the ventilation will not be adequate. And in the older jet ventilating laryngoscopes, we didn't have pressure monitoring, but now we have. Because you keep it above the glottis, there is always a chances of vocal cord movement. And FiO2 cannot deliver 100% FiO2 because there is entrainment of air. There is Venturi principle that comes into picture, and there is entrainment of air. So delivering 100% FiO2 becomes difficult in this technique. So this is a more advanced supraglottic jet ventilating laryngoscope with 5 integrated channels, where you have channel for high frequency jet ventilation, normal frequency jet ventilation, monitor the pressure, monitor the ETCO2. Also, you can humidify the gases because humidification is very important. Meghna explained us in detail why humidification is important. So these advanced scopes are equipped with all these newer adjuncts. Next, coming to transtracheal jet ventilation, we all know it as an emergency device. When we reach a stage of complete ventilatory failure, we try to do a needle cricothyrotomy and jet ventilate the patient to maintain oxygenation. But this can also be used for tubeless anesthesia surgeries. There are different cannulas based on the age, 13 gauge for adults, 14 gauge for children, and 16 gauge for neonates. So you can identify the cricothyroid membrane just like a needle cricothyrotomy. You puncture it, keep the cannula, and connect the jet to the cannula, and the surgeon operates from the top. A newer advancement in this field is the Ventrain, which is a single-use device where they provide you with the cannula and a hand-holding device, and the end is connected to an oxygen source. By releasing your fingers, you can ventilate the patient. One point which we need to remember here is the expiration is active here. The expiration is active, whereas in all other things, the expiration is passive. Here, the air is sucked out by, again, Venturi principle, which is there inside the machine. So what are the advantages of transtracheal technique? Again, it provides a tubeless field, and the FiO2 is reasonably good. Whatever you give reaches the patient because there is no entrainment. Coming to the disadvantages, yeah, it is incomplete control of ventilation. You don't know how much of air is egressing out, and it is contraindicated in critical stenosis because if you put in a catheter in a very small area of tracheal stenosis, it becomes like a cork in bottle phenomenon. There will be no space for air to egress out, so the airway pressure builds very rapidly and can lead to dangerous barotraumas. And again, we don't have any mechanism to measure airway pressures in this situation. So the third mechanism is subglottic jet ventilation, where we use, we call them as catheters. We don't call them tubes. We call them catheters because they are very, very small. It is around 2.8 mm diameter. And the top one is called as the Hansaker's catheter, and the bottom is called as a laser jet catheter. This laser jet catheter is laser resistant material, so you can use for even laser surgeries. Both of these come with a stillet, and they have one lumen to jet ventilate, another lumen to monitor your ETCO2. So just like your laryngoscopy, you do a laryngoscopy, place this catheter in the trachea and start jet ventilating the patient. So this is how the field looks. That is the catheter that you can see, and the field is relatively clear for the surgeon to operate. So the advantages is there is very, very minimal increase of airway pressure because there's a lot of space for the air to come out. And you can control FiO2 because there is no entrainment of air over here. And because of the additional channels that comes with the catheter, you can monitor the airway pressure and the ETCO2 monitoring. The only disadvantage here is the catheter is still in the field, but the surgeon can move it this side and that side based upon the site of surgery, and still it works well. Another point which has to be discussed here is the tubeless anesthesia for laser surgeries. Airway fire can happen to any one of us, especially handling lasers in the airway. We all know it is a triad: the fuel, the oxidizers, and the igniters. The fuel here is the nursing team, because the Lenin can act as a fuel. Then patient drapes, alcohol preparations, all these things acts as a fuel. And we as anesthesiologists are the oxidizers. We provide oxygen. Oxygen is needed for fire. So we are the oxidizers, and the surgeons are the igniters, because they'll be using cautery lasers. So how do we prevent this? All the staff members should be trained, and they should know the familiar concepts and the protocols needed to handle an airway fire. We should reduce the FiO2 to 30% or just 0.3. And by following tubeless anesthesia, we are taking out one major component, that is one of the fuel we are taking out. Because tube is combustible, if you are able to take out the tube and provide an anesthesia without a tube, that part we are more safe. If you look at the evidence, both Thrive and high frequency jet ventilation has been used very commonly in present day practice, and good studies have come and told that these studies are very, very effective and safe, especially in patients, especially in anesthetists who have experience in it. Please mark the word, you need to be very experienced. Just because we have heard about tubeless anesthesia, you can't go and practice tomorrow until and unless you completely understand the physiological concepts and the equipments that is involved here. And I request you all to go back and understand more of this and start using this as a technique. So to take home, apneic oxygenation plays a vital role in modern anesthesia practice, offering wide applicability across various clinical settings. Tubeless anesthesia is a valuable technique of airway management, especially in the hands of experienced anesthetists and surgeons. Success with these approaches depends on a strong understanding of, you should understand the physiology, you should understand the equipment, you should understand the technique, and you should also understand the surgical procedure. And you all know it is a multidisciplinary approach. So with clear and effective communication between all the team members, it is absolutely essential to have effective communication for giving a very good patient safety and safer outcomes. Thank you for the opportunity.
Thank you, Dr. Anup, for that comprehensive presentation on the utility of the apneic oxygenation techniques, the various modes of doing the tubeless anesthesia techniques, including the HFNO, Thrive, jet ventilation. And one thing is, I could see the both scientist and artist in your presentation. The good pictures, videos, and the way of narration. And one disclaimer is we have defined our own definition. There is no standard universally accepted definition what is to be called as tubeless techniques. Remember, many a times people think what we provide as a face mask, sedation, and some peripheral surgery is not tubeless. It is always any surgery done on only airways. Endotracheal tube should be considered as tubeless technique. And indiscriminate usage should be avoided. It requires a multidisciplinary discussion and a shared decision making between all the stakeholders. All the technician, the surgeon, anesthesiologist, nursing staff, everyone should be on a common page. Everyone should know how to troubleshoot. Then only we should resort for these high risk tubeless techniques. With this, we'll conclude the lectures, and we are open for the discussions. I could see a few questions in chat box. With Meenakshi, the advisor's chairman's permission, can we go for the chat discussion, sir?
Yes.
The first question is, any one of you can take. If it is not there, then I'll take. You can raise the hand, Hrullekha, Meghana, or Anup. You can just try so that you can answer. There should not be disturbances in discussion. The first question is from Meenakshi, sir. Can you perform tracheal resection and anastomosis by tubeless anesthesia for a case of endotracheal tube induced tracheal stenosis? No.
Sir, the best method for a tracheal resection and anastomosis is a subglottic jet ventilation, sir, because it provides an access also. So you can place the jet and you can suture the end-to-end trachea around. It provides an access for us to do it. That is what is given in the literature, that tracheal anastomosis is better with the subglottic jet ventilation, sir. Anil, sir, any thoughts?
So what we can do is, always till the trachea is resected, you can pass a small microlaryngeal tube if it allows. The smallest microlaryngeal tube available is 4 number size. Till the surgeon dissects it, you can place that. Once the trachea is transected, to the distal end, you can pass either the jet or the now available in India for a very cheap rate, around 60,000 rupees. The tri-tube is available, which is about 4 millimeter diameter. You do to the distal component, you can pass that till the surgeon creates a bed. And once it is done, you can also pass the jet from the proximal, that is to the oropharyngeal cavity, so that the oxygenation is occurring. Only thing we need to be mindful about the flow what we keep. This answers the other question somebody has asked. The flow should be very low, somewhere between 2 to 4 liters. If more the flow, it causes entrainment of air and it causes more damage to the distal trachea. So we have done a couple of cases where the smaller tube can be passed, the surgeon can create a bed and start suturing. Once the suturing is done, because even the bronchial blockers can be used as a medium to pass an oxygen if it is available in the institute. Or any small tube. Again, it depends upon what is the size of a subglottic stenosis. If it is a critical stenosis, which we call it as anything less than 3 millimeter, then you should go for upper tracheostomy, dilate the upper airway, then prepare the bed for tracheal anastomosis, resection and anastomosis. This is the answer.
So
I think we hope I answered. Sir is happy with that.
Actually, I want to say it is not a subglottic stenosis. I specifically asked that question. See, which I have anesthetized 22 years back. So now I can imagine how I have done that, because you are saying so much, but actually you have to see a case. Then only you can decide that, because it is very difficult. It will not be like that as you predicted, because the patient will be breathing by stridor, by getting that inspiratory drive. But once you paralyze the patient, I don't think that we can ventilate the patient. But the way in which you say with the transtracheal catheters or these microlaryngeal catheters with the increased flow, you can do that. But now I wonder, 22 years back, it was not available. See, actually, the first case, I have done 6. But first case, how we did, just because the patient is maintaining oxygenation only by spontaneous breathing, I induced her with inhalation induction. At that time, it was only halothane. Then I have put in endotracheal tube 7 size, because the patient is breathing through that slit to us only 3 millimeter actually, that slit because of the web. So she was breathing, the surgeon resected, and once he has resected, another endotracheal tube fluxometallic was passed through the distal end. Then he has closed the posterior surface. We have removed the distal tube, then pushed the proximal tube into the distal segment. Then he has sutured it anterior aspect. Again, the problem comes, he said the patient should not cough. If the patient coughs, the sutures will give way. Then again, I induced her with halothane after reversing spontaneous. Then with under halothane anesthesia, first extubation was done. Even then, he was worried. So he has applied a POP in the neck, so that the head was in the neck was in the flexed position. So the way in which you described, now the anesthesiology has advanced so much. Anyway, I have to see a tracheal resection, and because for tracheobronchial tumor, it is practiced. As Dr. Anil said, that endobronchial blockers, everything is practiced. I have to check whether this tracheal resection and anastomosis can be performed like that with the catheter.
I'll send you a video, sir, after this.
Yeah, thank you.
You can watch. And that the same number what we're talking about, 7 number tube, instead that we are passing a very small tube. So some mode of oxygenation is always there into the patient. The same principles with different tube size. Then Dr. Muthu Kumar Rajgopalan has asked, can we deliver a HFNO beyond glottis using some small catheters during vocal cord surgery. Again, the same question, the similar answer for this. Only thing you can pass, but you should be worried about the flows what you are giving. High flows are never advocated near the subglottic region for a risk of the entrainment of air, and there should always be airway should be patent. If airway is not patent, it causes ingression of air and there is no way the air can come out. So that we should be mindful. So flow has to be limited to 2 to 4 liters.
Maximum they tell is 2 liters, no, sir, for such intratracheal lesions.
Low the flow, better the oxygenation and less complications. The relaxants are administered as boluses or infusion in laryngeal surgeries with tubeless anesthesia. We put only the loading dose of drug. Majority of we use tubeless techniques as a crisis battling. That means as a stopgap techniques, not as an absolute techniques in all the cases. Suppose if there is a tracheal stenosis, as Anup was showing in his video, till it is dilated, which takes maximum about 20 to 30 minutes. Once the airway is created, we'll go for a definitive airway, protect the airway and go ahead with the surgeries. Second is, the next question is, how do we choose patients between NIV and HFNO? Do we have some criteria in ICU? Anybody wants to take this? How to choose between HFNO and NIV? If not, yes, Anu.
Sir, an HFNO is better because patient tolerability is better, humidification is better, and the work of breathing is reduced, and it also produces.
Question is, how do you choose between those two when both are available in ICU? Is there any
specific criteria we don't use, sir? I don't exactly know, but generally what we use is, especially during COVID when we saw HFNO gave a better result than the NIV. So because it reduces
the question is, how will you choose that particular? I think Meghna wants to answer. How will you choose whether this candidate is going to do good with NIV or good with HFNO? Yes, Meghna.
Meghna, you have to unmute yourself. Dr. Meghna, yes. Unmute yourself.
Yes, sir.
Anyway, before you answer, I will add that corollary. See, this question will have practical applications in newborn. Because in newborn, the pediatricians are finding it difficult. Some people will be using nasal CPAP or some people will be using HFNO. So that question is having some valid points we have to clarify.
Sir, there is no clear-cut criteria saying in this patient you have to use an NIV, in this patient you have to use HFNO. There are various studies that are undertaken to say that in these situations HFNO can be used with some benefits. One of those where HFNO can be used with some benefits is when you provide it in patients with hypoxemic respiratory failure but without other organ involvements. Whereas if there is other organ involvements, it is recommended to not use this HFNO. The other way they've divided is HFNO can be used in these situations with certain benefits that are not clear. One of them they say is post-extubation after cardiothoracic surgeries. And again, after extubation in low-risk patients, they've said HFNO can be used with some benefits. So if you see the articles or works that have been published, there is no criteria, at least that I could find, but they've just described that conditions where you can use it with some benefits, without any clear benefits, and to not be used.
So to take home is, the first thing, the patient should be a candidate to use an NIV. Whether you want to use HFNO or NIV, that means you should rule out that patient is having always a good efforts. That means you should have an inspiratory drive to use that. Suppose the patient is unconscious, you should not use both. If patient is having compromised airway in ICU, you should not use both. If patient is having upper GI bleeding, imminent cardiac and respiratory arrest, these are absolute no-no for either HFNO as NIV. Only one advantage of using HFNO is in hypoxemic, that is type 1 respiratory failure. It has got an beneficial over NIV. Suppose if your particular patient requires the high pressure, driving pressure, then the NIV should be the choice. If patient is having hypercapnic, that is type 2 respiratory failure, patient should go for NIV. If patient is not tolerating NIV, then you can switch over to HFNC because of the better compliance. So these are the set available I do not say as a guideline. These are the available parameters that we can choose one between the other. But always it is the patient who drives, who tells us which is better depending on the clinical criteria, how he is improving on it. But there are no set guidelines regarding whether how to choose NIV or HFN. The next question is, what is the EtCO2 level you allow during tubeless anesthesia? One unfortunate thing is EtCO2 cannot be maintained, cannot be monitored, though the newer models have come with an EtCO2 module, but it gives a trend whether what is happening there, but there is no absolute value because it was introduced only last year with HFNO. Otherwise, because of the 60 liters of flow, the carbon dioxide is getting washed off. There is no catheter which can hold it and read us what is the EtCO2, what is happening. But a trend gives us some of the clue, but there is no absolute value cannot be predicted on or monitored with HFNO.
1 second. Sorry for the interruption, because that is the idea of asking the question. Dr. Anup has shown that EtCO2 was 60 and they have not disturbed it. And again, it was mask ventilated and was brought to 40 after introducing IGL. That is the reason why that question was asked. How they
observation is a good observation. What Dr. Anup was talking about is at the end or the conclusion of a surgery of a tubeless technique. Because for ethical reasons, we cannot have an arterial line to sway carbon dioxide in all the patients. So what we have done is we just held the mask at the conclusion of a surgery and give 2-3 breaths. We will see the trend, what is happening. So in EtCO2 wise at the conclusion of surgery about 20-30 minutes, whatever the clips you were showing, in that particular patient, the maximum reading that was there is 67. That means to say in a physiologically normal patient, even in many times we do hypercapnic, we do an acceptance of high carbon dioxide. The patient clinically will not suffer as that is given in the literature that high carbon dioxide is going to cause deleterious effect on the organ. That was a take-home message from that clip. Then what is the maximum duration? You have performed the tubeless anesthesia as Meghana has already performed in our institute. 63 minutes. Dr. Anil Patel was surprised when we happened to meet and discuss. He described his 50 minutes in his 2015 publication, and that is in 2015 publication. We went beyond that, but we have published also these whatever the timings we have shown. Then Dr. Vinod Kumar is asking, what is the maximum duration of tubeless anesthesia? Very difficult to say arbitrarily that this patient is 50 minutes, 20 minutes. Again, maximum, most of the literature so far available till today have said 20 minutes is the optimal time you can well maintain. Again, after 20 minutes, again depends upon the patient condition, how he is behaving, what airway is patent or not, whether he is not desaturating, all those things will take priority. Can tubeless anesthesia be given for prolonged duration? Yes, we have done up to about an hour. Again, it should be from an experienced hand in a very controlled environment where all the gadgets to secure an airway should be present. Post-op pulmonary complications encountered. So far, we have done 167 cases, no post-op pulmonary complication. Of course, we had an intraoperative complications like bleeding, where we have to intubate. Anup has shown a video where the patient desaturated in between, where we have troubleshooted. With an experience, we have learned our own way of troubleshooting these situations. So I think I've answered all the question in chat box. Meenakshi sir, anything else?
Yes, over. We can conclude because it is already 7:50.
Yes, sir.
So
2 minutes
because-
or more.
No,
2
yes.
minutes or more. So
See,
with this, we are
7:45 we aim. And anyway, just because you say your observation is good, we are here to observe only what is happening when stalwarts are talking. Even I can say Dr. Meghna's slide, instead of decreasing, that is HFNO, she has mentioned she can check. So that is R was missing, spelling mistake, decreasing. DEC, R was missing. Then EA was coming. You can check HFNO.
Yes, sir.
We are here to see only when we have to make use of the opportunity where we can go and read. So always it is better to listen than to read. It is a waste of time reading. It is very good. It is easy. That is the reason I say Miller and Harrison I used to appreciate, because when I purchased Miller, it was 8,000 rupees. See, the entire brain, all his work, he has given it for 8,000 rupees. Whereas I have minted money with that 8,000 rupees by investing. So always brain should be appreciated, right? Swastika is restless. She wants to close.
No, sir. No, sir.
Right. Anyway, now it is my duty. See, I have to thank all the faculty profusely because the JSS faculty has proved their worth. Even Dr. Hrullekha, the youngest faculty, she has done very well pre and para oxygenation. It is very clear. It was followed by Dr. Meghana. So she was magnanimous in spending her time for the benefit of the youngsters. She has explained all the philosophies behind this tubeless anesthesia, which was followed by Dr. Anup for a wonderful demonstration of videos. I think it is good. It is a good trend to see our own people are performing. So instead of saying Jack et al. Performed in California in Massachusetts hospital, it is very easy, na, Dr. Anup. So if at all I have a doubt, we can fly, come to Mysuru and we can see. In addition to enjoying Mysuru dosa, we can see this also. So it is quite nice to see at least we can pronounce the names instead of finding it very difficult. Every time we say Ronald Miller. So now we can say Anup, Anil Kumar, Meghna, and the future Hrullekha will also be coming to that picture. So I think she can rule 2 states, the Andhra and Karnataka. So it was good moderation by Dr. Anil. He has expressed in clear terms his knowledge and the same enthusiasm. It is quite interesting to see a professor is really interested, just like a college guy. He is explaining everything and he is having definite ideas. And I request Dr. Anil to use his intelligence and academic caliber in future also to educate the youngsters. And see, we have picked up Dr. Anup even 3 years back in our Puthukkottai Bhudhan First Edition. So many postgraduates at that time participated. They are participating as assistants in this episode. So we are also happy. Because of Puthukkottai Bhudhan, we have developed contacts throughout the country who are all the keen academicians, and JSS deserves a lot many congratulations. And we congratulate and thanks to the entire team led by Dr. Anil Kumar. And now over to Clearnet for their concluding remarks.
So, thank you so much, sir, for the wonderful deliberation and wonderful session for today. And again, thank you to all the dignitaries present here. Clarity is really glad to have all these brilliant people together in this session today. And I really hope that you all had a seamless experience. So, with everyone's permission, I am concluding the session in here for today and looking forward to host you again. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you. Good night.
Sir.